I will be talking about chronic coronary syndrome. This we often see most of the people come with a recent onset effort intolerance or chest heaviness on exertion. What next? We know that coronary disease presents in two ways. One is acute coronary syndrome. The second one is chronic coronary syndrome. Acute coronary syndrome includes the STEMI, non-ST elevation MI, sudden cardiac death, unstable angina. And chronic coronary syndrome was recently coined name, maybe after 2018 or so. It includes stable angina, what we call chronic stable angina, new onset heart failure or LV dysfunction when we suspected coronary heart disease, and 1 year after our acute coronary syndrome, and 1 year after PCI and CABG, suspected microvascular and vasospastic angina, as well as silent MI. These all groups are included in this chronic coronary syndrome. And the difference is chronic coronary syndrome is a stable patient. They come as OP patient. And anytime they can destabilize and go to the acute phase also, or heart failure. Then evaluation is very challenging because it is having a miscellaneous group. So difficult to evaluate because of the following reasons. And the evaluation includes clinical, which includes history and physical examination, as all we know. Then the initial diagnosis test, lipid profile, fasting blood sugar, ECG, and in selected cases, TROPI. Then we assess the probability of occlusive CAD by some score, that is risk factor helped clinical likelihood. That likelihood has to be assessed in each population. Then we can have non-invasive evaluation, that is functional, which can be treadmill test, dobutamine stress echo, stress myocardial perfusion imaging, and stress, there is PET also stress CMR also, that is cardiac MRI. And non-invasive includes, non-invasive anatomic includes echo, calcium score, coronary, CT coronary angiogram, and invasive, as we know, coronary angiogram, and sometimes IVS and OCT. And invasive functional, we use fractional flow reserve. About the stepwise, the ESC, European guidelines suggest a stepwise approach for evaluation of the chronic coronary syndrome. That step one, the initial history and all. Step two, that likelihood, assessment of the likelihood. Step three is diagnosis, and step four is management. The step one, we already know the clinical evaluation, history and physical examination. Most of us know, and we are not going to detail. ECG, basic blood test as shown, and in some cases chest X-ray and PFT to rule out pericardial or pulmonary cases. The step two, assess likelihood of obstructive CAD. This is risk factor weighted clinical likelihood, which can be assessed by symptoms, then risk factors. And from this chart, we can assess how much likelihood is there for the occlusive CAD. And we have categorized them into 5 groups: very low, less than 5% likelihood; low, 5 to 15%; moderate, 15 to 50%; and high, 50 to 85%; and very high is more than 85%. And AHA classifies slightly differently. I am not going to that. And transthoracic echo also has to be done in the second stage. That step 2, assessing the RWMA, LV ejection fraction, and we can rule out that valvular heart disease, pericardial disease, cardiomyopathies, and pulmonary artery hypertension can be ruled out. And then when there is a poor echo window, you can give a contrast echo, or we can do a rushed cardiac MRI to assess the LV function. That exercise is widely accessible and available. It's low cost, no radiation. In low pretest likelihood group, that is 5 to 15% group, If it is a negative TMT, we can down classify the patients into the very low risk group of less than 5%. And limited access to functional testing, like there is no availability of CT, coronary angio, MRI is doubtful, we can go for exercise, ECG is very useful in this group. Although the main problem is that there is a lot of inconclusive results. So limitations are abnormal when patient is having a resting ECG is abnormal, like WPW syndrome, LBBB, LV hypertrophy, and patient on digoxin. This cannot be done. Low sensitivity, on about 42% patients with positive results. We are missing about 42%, and we are overdiagnosing about 38% by treadmill test. Inconclusive findings common. Inadequate heart rate response, we will not get the adequate positivity. Handicapped, elderly, obese patients we cannot do, and low diagnostic performance. But mainly useful in risk stratification in a very low risk group or low risk group. Assessment of exercise tolerance, symptom relation, arrhythmias, and BP response can be assessed only by this stress test or TMT. Step 3 is confirming the diagnosis. We have non-invasive tests like anatomic, calcium score, as well as CT coronary angiogram, and functional we can stress echo, MPA, SPECT, and PET CT, and cardiac MR. And invasive, we have anatomical, invasive coronary angiogram, and functional we have FFR. We can see that the CT coronary angiogram, stress PET or stress SPECT, stress CMR, and stress echo, all these comes as class 1 indication, while exercise ECG, TMT is class 2. Coronary artery calcium score. Coronary artery calcium is usually a calcified plaque. So when there is a high calcium score, it indicates high risk of events. And different studies have shown that when the calcium score is high, mortality increases, incidence of MI, stroke, heart failure, and atrial fibrillation are high in patients with a high calcium score. This is how it looks in CT. And this can be classified to different groups: 0, no calcium; 1 to 100, mild; 100 to 300, 400 is moderate; 400 to 1000 is severe; and more than 1000 is extensive. And low clinical likelihood, that is 5 to 15% group, and intermediate risk of AHA class. If they have a calcium score of 0, we can down classify into very low risk group. So when there is 0, it goes to less than 5% likelihood group. And when score is more than 400, it goes to higher group. And very low likelihood patients, if patient have a strong family history, hyperlipidemia, familial, increased lipoprotein A, and systemic inflammation, these patients go to the higher group. And calcium score more than 100 goes to a higher clinical group. And very low and low likelihood obstructive CAD constitute approximately 85% of the chronic coronary syndrome. And if coronary calcium score is more than 300, it is equivalent to established ASCVD. This is the confirmed registry, which shows that about 4,500 patients, the calcium score of more than 300, the events are almost same as established coronary artery disease. The CT coronary angiogram is non-invasive, needs IV contrast, needs slow, regular heart rate, and impaired kidney function and heavy calcified coronaries is a problem, and needs breath holding. And the Scott heart trial showed a small but significant decrease in 5-year combined endpoints when coronary CT angiogram was performed in addition to exercise ECG. And CT coronary angiogram versus functional CCTA is slightly better because it can assess non-occlusive occlusion also. And borderline lesions, we need FFR CT or an invasive FFR. This is a 68-year-old male, hypertensive lipidemia, TMT borderline test. And when we see the CT angiogram showed about 25 to 50% plaque which needed aggressive risk factor modification and preventive pharmacology, so that if we stopped at TMT level, we should have missed this patient. The future, it is a quantitative plaque analysis can be done, and we can have a CT FFR also is coming up. Functional imaging, all these four categories. Stress echo is just detected by the regional wall thickening abnormalities induced by increased myocardial oxygen demand, like it may be due to with exercise, dobutamine or vasodilators. And the class 1B indication in individuals suspected of chronic coronary syndrome and moderate or high probability for CAD. Then stress echo is recommended to diagnose myocardial ischemia and estimate risk of MACE. Stress echo is widely available, low cost, bedside, no radiation, can be repeated several times, operator dependent, image quality, problem in obesity and COPD, and ultrasonological contrast can be used to improve image as well as assess perfusion. And less than 10% perfusion abnormality may be missed if in the stress echo. And SPECT MPI technetium use reduced nuclear tracer uptake and retention in hypoperfusion or ischemia during stress and vasodilatation. Good accuracy, limitation in multivascular disease, multivessel disease. And PET-CT, these above tracers are used, rest and stress and superior perfusion images, less radiation. Quantitative assessment of the myocardial blood flow is possible and most useful in multivessel disease and microvascular dysfunction. And obesity, young multivessel disease, microvascular dysfunction, this is a very good choice. Problem is cost and availability. Cardiac MRI, cardiac volumes, function, cardiac anatomy, tissue characterization can be done. Assess perfusion also. Coronary MR angiography is in evolving phase, and limitation is limited availability. Claustrophobia, patient cannot do it. Duration, which takes long time. And contraindication in all the type of ICDs and pacemakers. The invasive coronary angiogram, ICA with FFR is indicated in patients with a very high risk, more than 85% clinical likelihood. We can straight away go for angiogram, and FFR for functional assessment of stenosis, and IVAS and OCT for anatomical assessment of the plaque. Evaluation algorithm, estimate likelihood from clinical as well as risk factors, adjust according to the abnormal clinical and investigation findings, and reclassify low risk factor clinical likelihood using coronary calcium score. And if there is a very high risk, they straight away go to invasive coronary angiogram. High risk, 50 to 85%, high clinical likelihood, you can go functional imaging, any one of them. And moderate, you can go either CT coronary angiogram or functional. And low, you can go to unjust likelihood and do coronary angiogram, CT coronary angiogram. And very low, you can defer further testing. In conclusion, chronic coronary syndrome is a relatively stable patient. Miscellaneous group, likelihood of CAD is assessed by clinical and risk factors. And this can be modified by ECG, echo, TMT, and arrhythmia or PVOD. And majority belong to the very low or low risk group, 85%, needs risk factor modification and medical management only. And low moderate, you can needs CT coronary angiogram. Moderate to high risk needs functional imaging, and very high risk needs invasive coronary angiogram, and borderline lesions need FFR and IVAS and OCT for complex angioplasty. Thank you for patience.
As physicians, we used to see patients with the chronic inflammatory states like autoimmune diseases and chronic rheumatological conditions like rheumatoid arthritis patients. They come with a slight chest pain. Sometimes there won't be much symptoms. So always, I think we used to see sudden cardiac death also in rheumatoid patients. So all the chronic inflammatory states, whether it is autoimmune, whether it is diabetes, whether it is chronic kidney disease or chronic liver disease, always, all physicians, I think we should care the mild symptoms of chest pain or dyspnea of that patient. I have seen so many rheumatoid patients coming at sudden cardiac death in emergency situation. Also, the chronic kidney disease patients. So, is there any guidelines or in KDIG or any other guidelines for evaluation of chronic coronary syndrome in these patients? If it's there, in what all conditions we should check for? Obviously, from these slides, we should check the risk score in almost all these patients. If it is very high score, we should definitely do the invasive coronary angiogram. Is there any other points or any guidelines? Is there?
I think we have to assess the likelihood, clinical likelihood. Then we can have functional testing. In a CKD patient, ideally it can be MRI may be preferable, CMR may be possible to rule out or rule in any coronary abnormalities. Other patient, other functional tests can do.
CKD itself is a high-risk situation, so there is no need of risk assessment because CKD falls automatically into the high-risk situation. Moderate to severe CKD is high risk. CKD, you brought that in. It's an important topic for discussion. CKD means most of the people, rights of the CKD patients that you cannot use the dye. Now you cannot go for a coronary angiography. Your fate is only medical therapy, not like that. Because one of the largest studies of chronic coronary syndrome, ischemia trial, they had a sub-study called ischemia CKD. They found those patients who have undergone coronary angiography, their need for dialysis therapy, their need for, and the chance of a death due to the contrast-related acute kidney injury is extremely low. So we take if necessary, we will take the precautions and take up the patient for coronary angiography because CKD patients dies of coronary artery disease. They don't die of usually CKD per se. Most of them die due to coronary artery disease. So with adequate precautions, with a discussion between the patients, it's a shared decision making. Majority of them can undergo coronary angiography. And those patients who are dialysis dependent or renal replacement therapy, then there is no issue. We can easily take them up for a coronary angiography. Problem is they usually have very complex disease.
Coronary calcium scoring, is it the calcification coronary is as equivalent as a coronary disease, right?
It is actually the events when we follow a patient with a calcium score. If it is above 300, it is almost same as established coronary artery disease or ASCVD, atherosclerotic coronary disease.
Unlike the dystrophic calcification of other vessels, coronary calcification is equated as a coronary IHD, CAD.
The concept is it is a calcified plaque. So already the plaque is there. So we have to then immediately they goes for they need statin. If it is more than 300, probably they need aspirin also.
CT scoring is a very simple thing.
Very simple. There is no need of dye, only minimal radiation, and this can be done by everybody. Especially
treadmill we usually miss. Single vessel disease and branch disease usually missed in treadmill.
TMT is sometimes it can be very disruptive. Those people who can exercise up to 12 minutes of Bruce protocol, where we consider them, they are ready or they are fit to undergo any sports, including squash. They may come up after 1 month with a acute coronary syndrome. So TMT has got no positive predictive value, no high positive predictive value. At good workload, if the treadmill is negative, their chance of an event is less than 1% in the next 1 year. Coronary calcium score, I think, is coming up as an excellent and non-invasive technique because it is equated to, as Dr. Iqbal said, it is equated to coronary atherosclerosis. Our aim for prevention is to keep the coronary artery score at 0. If it is 0, it should not progress. We have to keep it at 0. And more than 300 is considered to be equivalent to established atherosclerotic coronary artery disease. So you have discussed a lot many investigations. So we have two types of chronic coronary syndrome. A chronic coronary syndrome with no obstructive coronary artery disease. That is the INOCA, ischemia, non-obstructive coronary artery disease. Mostly it is a microvascular disease. Another is with obstructive coronary artery disease. We have only 3 or 4 tools at hand, isn't it? Clinical, electrocardiography, echocardiography, treadmill test, coronary CT angiography, and invasive coronary angiography. Rest of the nuclear studies are of limited practical utility because of the availability, expertise, and the cost also. With these 5 tools, I think we can manage 99% of our cases. Isn't it? Manikandan, what is your opinion?
Definitely.
These are practically, these 5 things are sufficient. A clinical treadmill test for those patients with interpretable electrocardiogram, no contraindications, it gives a baseline idea. And the next step is a coronary calcium score or a coronary CT angiography. A CT angiography, the problem is the dye usage is 100 ml, close to 100 ml. Radiation is a little higher than that of an invasive coronary angiography. And in our state, the invasive coronary angiography is a simple procedure. It's invasive, but it's a simple procedure. The complication rate is less than 1%. The contrast use is less. The radiation use is less. That doesn't mean that every patient with chronic coronary syndrome or chest pain should undergo invasive coronary angiography. It's a judicious decision making. Any question? We can entertain 1 or 2 questions from the floor.
I think since we have a lot of physician friends, people have a notion that echocardiography is a very good tool. I think people should realize that echo is a very poor investigation to identify our risk stratification. Even treadmill, we discussed about it, is now gradually going away. We have better imaging when the calcium scoring without CT. No, we don't need a CT imaging for calcium scoring. So that possibly is the best way.
Take it like that. So a patient had undergone a treadmill, good workload, negative MD if you ask. So does this means I don't have coronary artery disease? No. You may have coronary artery disease, but the risk of development uneven is low. Unisar, what is your opinion?
No, echo anyhow is useless. Unless an event has happened, echo will be normal. Even if a patient who is going to have an MI tomorrow, his echo can be normal. But treadmill usually, if you walk for 12 minutes and has no symptoms, that it definitely indicates a good prognosis. You may be missing a diagonal or an OM1, but major left main or triple vessel disease, you can definitely exclude with the treadmill. And there again, I think what is more important is not whether it is positive or negative. It is the effort tolerance. Somebody who has walked 3 minutes and is negative has a worse prognosis than somebody who has walked 15 minutes and is positive. So it is effort tolerance rather than whether it is positive or negative that is important.